not give it to is a very important question. So conventional clinical pathologic features do not discriminate risk, and they certainly do not discriminate oxaliplatin benefit. Again, lymphovascular invasion, poorly differentiation, number of lymph nodes have nothing to do with oxaliplatin, okay? All right. So they looked at a oxaliplatin-containing combination. This was Phlox. This is the NSABP, okay? Here are the specimens, 2,400 patients, 77% were included in the analysis, okay? They only did half. There's a reason behind that, but they only did half initially. Again, recurrence score, the higher recurrence score, the higher the risk of recurrence, the higher the hazard ratio. Statistically significant, okay? As you would expect, stage 2 patients do better than stage 3, or another way to say this is stage 3 patients do worse than stage 2, and that's why they have a high hazard ratio. Stage 3C patients, these are the T4 N2 patients, do worse than stage 2, and that's why their hazard ratio is elevated. So again, very helpful internal control data. This helps us understand that the data set is a good data set. Here are the curves. What you see is the solid line and then the oxaliplatin containing arm, okay? And this is recurrence risk at 5 years, and this is the score, okay? So what does this show us? Stage 3 A and B. Here, adding oxaliplatin lowers your risk, okay? We know that. That's what it's supposed to do, right? That's why we give oxaliplatin. So clearly, 5-FU alone, 5-FU oxaliplatin lowers your 5-year recurrence risk. Stage 2, no difference really down here, but as you come up here, you start to see oxaliplatin does give some benefit to these patients that are high risk, okay? Stage 3 patients, 3C patients, N2, T4 lesions, these curves are parallel, okay? We treat all of these patients, okay? We treat most stage 3s, despite the toxicities. But these patients, N2 disease, T4 lesions, we're gonna treat all of them, okay? So we do see a difference in oxaliplatin, with oxaliplatin, in terms of the recurrence score. It's lower. In each of these curves, it's lower. Okay. Let's look at this in greater detail, okay? So here, the white group is the low-risk group, okay? So again, these are the patients who have recurrence score, oncotype colon assay score of about 30 or less, okay? These patients, the benefit from oxaliplatin is not great, okay? Here, the solid line and the dotted line showing the difference, okay? So you would argue that if you're a stage 3 colon cancer patient and you have a low risk of recurrence, perhaps it's okay to treat with 5-FU alone. You don't need to subject the patient to oxaliplatin toxicity, okay? Also, in the global colon cancer adjuvant trial, okay, the global colon cancer adjuvant trial is patients from the US, Scotland, Greece, Spain, okay? I think they're all enrolling patients trying to decide whether 3 months is equal to 6 months of chemotherapy, okay? If you had a score that was low risk and the trial was equivalent, you could argue that these are the patients that should get 3 months of chemotherapy, and you would spare them significant time, anxiety, and toxicity, okay? So again, I'm jumping ahead, I'm talking about trials in the future, but that's where this is helpful. Now here in the green line, the intermediates, again, you go from this surgery alone, or I'm sorry, 5-FU alone arm to the 5-FU oxaliplatin benefit. So again, this argues that you have to treat patients, okay? Same thing in the red, you really have to give them chemotherapy because the benefit, the difference between this line and this curve, this green line and the dashed curve is significant. All right, so that's where this is helpful. That's why getting the oncotype score is helpful. Okay, so again, internal controls and multivariate analysis. I showed you this earlier, stage 3s ABs and stage 2s, 3Cs and 2s. In terms of treatment, oxaliplatin is better. Mismatch repair, again, favorable outcome, hazard ratio 0.27, and again, recurrence score helps predict. All right. So how do you apply this? This is the report that you might get on a stage 3 patient. If you're at low risk, okay, the benefit between the solid line and the dashed line isn't so different, but when you come over here in the high risk group, okay, the difference is greater. And again, these are the patients that will benefit more. The delta between the solid line and the dashed line is greater. These are the patients that are going to benefit more from oxaliplatin-containing chemotherapy. And again, recurrence score risk right at 41. Those patients are high risk. These patients are low risk, and you might spare them oxaliplatin toxicity. Okay? So that's, again, where this test is helpful. This is how we use it. All right. So let's move on. The conclusions from the CO7. The recurrence score predicts for recurrence risk in stage 2 and now stage 3 patients treated with not only 5-FU, but 5-FU oxaliplatin. Similar risk reduction observed in oxaliplatin-treated patients across the recurrence score range. And the recurrence score helps us discriminate which patients need oxaliplatin and which patients don't need oxaliplatin. Okay? So again, very helpful, practical. All right. So we have all this data now, okay? This is all retrospective, prospective but retrospective. So we need a prospective study, okay? We need to show, or we need to know, how does this assay, how does this test actually change practicing oncologists' decisions, okay? I mean, I think as I sit in an audience, I want to know, if we're going to use a test, how is it actually helpful? Okay, so that brings us to our study. Prospective evaluation of the oncotype colon in stage 2 treated patients, okay? Very important person. No, just kidding. All right. Okay, so it's a prospective study, 200 patients, all T3N0, 17 really community. The only academic sites were the 3 Mayo sites, but really community sites, 105 oncologists, okay? So the patients the oncologist identified patients with T3N0 tumors. They filled out a questionnaire. They went on, submitted mismatch repair, defective mismatch repair testing, and then oncotype DX testing. If they were oncotype DX, no one received treatment, which is the practice in the United States. If they were proficient, and we got the score back, a decision was made after a post-questionnaire was performed, okay? Did this result change this proposed treatment or observation when the score came back, okay? That's the question. Does it change what you do? Does it impact the score, the oncotype DX colon score, impact what you do, okay? And the answer is yes, very clearly. It impacted what the oncologist decided to do, and also what the patients decided to do, because the patients also filled out these questionnaires. It was not only the oncologist, but also the patients. 45% of decisions were changed. Almost half of the decisions were changed. 33% were for less treatment, meaning observation, no chemotherapy. 11% were for more intense chemotherapy, okay? So maybe the patient was to be observed. A decision was made to give them chemotherapy because they had a high recurrence score. Or they had a high recurrence score, and instead of just giving 5-FU, the oncologist decided to give 5-FU oxaliplatin, okay? So 11% increased their treatment recommendations. 33% lowered the intensity of their treatment, mainly observation. And that's shown here. This was before the oncotype result. You see here in the green observation, 5-FU, oxaliplatin, FOLFOX. And then after the result, more patients were low recurrence score risk, therefore more patients were observed. Less patients got 5-FU, less patients got oxaliplatin, okay? Again, the oncotype score impacted how Mayo and community oncologists treated the patients. Very practical, okay? This is real life. Okay. So the Mayo Clinic utility study, it's the first prospective study to assess the role of quantitative recurrence score in clinical decision-making for stage 2 patients that were mismatch repair proficient, okay? Again, we don't treat the mismatch repair deficient. We don't need to know what the curve is. We're not going to treat them. Treatment recommendations changed in 45% of the patients, and the direction of the changes were concordant with the recurrence score result, meaning if you were at low risk, you went to observation. If you were at high risk, you likely got oxaliplatin chemotherapy. Okay. Okay, so the summary for stage 2 colorectal cancer treatment, one needs to discuss the risks and the benefits with the patients, okay? There's always risk, despite our surgeons taking out the cancer and the majority of instances curing the patients, okay? There's still a risk the cancer will come back. The patient has to understand that that's a risk. They may do a CAT scan, they may do an X-ray, they don't see anything, but that doesn't mean that there aren't still cancer cells in their body, okay? So we have to educate them, inform them that there's still risk. So this is a very important discussion. We have to understand that all the recommended risk factors, the clinical pathologic risk factors, are prognostic. They are not predictive of 5-FU treatment benefit. They are not predictive of oxaliplatin benefit. They are not quantitative, okay? MSI testing for all stage 2 patients is recommended. No treatment is given to these individuals. We're investigating the MSI likes. Oxaliplatin-based chemotherapy is given for T4 tumors. 5-FU can be given to elderly patients. And again, as I started off today, we are in the era of personalized medicine. Our patients are demanding individualized medicine based on our molecular capabilities, and the Oncotype DX is the only test presently available. The other assays, coloprint, we don't use them. Stage 2, it allows us to decide which stage 2s to treat and which to give oxaliplatin. Okay, so let me just finish up. So this is an algorithm that we commonly use in stage 2 patients. Those that are mismatch repair proficient, T3, they get tested. MMR deficient, observation. T4, chemotherapy. Stage 3Cs, stage 3s, 3Cs, all get chemotherapy. Again, N2 disease, T4 lesions. Stage 2A, stage 2B, stage 3A, stage 3B, all get tested, okay? All right, so let's finish up. Let's go back to these cases. Let's just get let's just raise hands. Who wants to treat this patient? Does anybody want to give this patient chemotherapy? 1, 2, 2. Okay, 2 B. Who wants to give this patient chemotherapy? Okay, 1, 2, 2. Okay, 2 and 2, okay? These are the actual recurrence scores, okay? So for that patient, recurrence score was 58. Recurrence risk was 24%, too high, okay? Way over here. On this curve, way over here, okay? On this patient, recurrence score was 14. Recurrence risk was 12%, low, okay? Probably benefited by observation, okay? All right, now, who wants to treat this patient? There you go. You're just like the American audience, I have to tell you. They do the same thing. You're exactly the same. I did this in Brazil, too. Exactly the same. Okay, so the benefit in regards to chemotherapy is about 5%. The benefit here is lower. But most people will want to treat. And again, you cannot distinguish which of these patients should be treated. I would have said this patient because I think this is a left-sided tumor because of the lack of lymph nodes. I think this is a left-sided tumor. But this patient has the worst prognosis based on the Oncotype DX score. Okay? All right, there you go. Okay, that's it. Thank you very much for your attention, and I hope this is helpful. Thank you very much.